Our next speaker is Dr. Nicola Zamed. She studied at the University of Edinburgh and is currently consultant in diabetes and endocrinology at the Royal Infirmary of Edinburgh. Her first talk will be about prevention of diabetes.
Thank you very much for the kind invitation to come and speak to you. We've really enjoyed our time here. The conference so far has been really interesting, and yesterday we visited Jerash, where the guide asked me what I was talking about, and I said I was going to speak about prevention of diabetes. And he said two sentences and a gesture which have summarized the most important points of my talk. He said, yes, diabetes, there is a lot of it. Then he looked down at his tummy, which was large, and he patted it like this, and he said, I think this is the problem. So perhaps I should have brought the guide along to give the talk, because actually he has summarized the crux of the issue, which is that type 2 diabetes is a very extensive problem. We need to try and prevent it because we cannot deal with the scale if it continues to grow, and the association between central obesity and diabetes is central to this discussion. So I'm going to flesh out some of what he said, but I would like to say shukran to this guide who has really encapsulated the important messages that I want to give you today. So I'm going to talk mainly about lifestyle trials and the effect that they have on reduction of diabetes. I'm going to look at one lifestyle trial which looked at reduction of cardiovascular risk and what we can learn from that study in the context of diabetes prevention. I'm going to say a little bit about bariatric surgery in terms of prevention of diabetes. I'm purposefully not going to say much about the use of medication. There have been some studies looking at, for example, metformin and glitazones reducing the progression from impaired glucose tolerance to type 2 diabetes, but I think this is a hard thing to sell to patients. You're telling them you're preventing a condition, but you're putting them on the medication for that disease years ahead of when they need to be on it. But that may be something you wish to pick up on in questions. At the end, I will say a little bit about reversal of type 2 diabetes in the early stages, because there has been some research in the last few years in this area. I'm going to purposely focus on type 2 diabetes because that's where the majority of the problem lies, and because we have a clearly defined pre-diabetic state in the form of impaired glucose tolerance that we can target. And in fact, the successes in type 1 diabetes have been extremely limited and probably not worth discussing in this forum. So what I have here is really some general data from the International Diabetes Federation describing the scale of the problem, but in fact Dr. Haddad's talk has contextualized very clearly what the scale of the problem is in Jordan. But worldwide in 2012, more than 371 million people had diabetes. Unlike the figures that Dr. Haddad showed, which is prevalence, this is absolute numbers, so it's not surprising that the countries with the highest populations, shown up here, China, India, USA, are going to be the ones with the greatest numbers of people with type 2. But worryingly, down here, 8th on the scale, we see Egypt, a fairly close neighbour, and so we see that even though some of the Middle Eastern countries may not be the largest, they are producing a lot of people with type 2 diabetes. By the time we reach 2030, we're going to be in excess of 500 million people worldwide with diabetes, and 90% of that is type 2. So this is clearly a major public health threat. As Dr. Haddad has said, there is a large burden of undiagnosed disease, which the IDF is aware of, and in the Middle East and Africa, it's estimated that there's about 18 million undiagnosed cases of diabetes. Almost 5 million deaths in 2012 were attributable to diabetes, and that death rate is only expected to double. So we cannot deal with this problem if it continues to grow. We need to do what we can to stem the flow and reduce progression to type 2 diabetes. So how can we do that? Well, we can probably do that by focusing on obesity, because there are very close links between particularly central obesity and type 2 diabetes. The data shown here is from two longitudinal studies, the Nurses' Health Study in women and the Health Professional Studies in men, which looked at the effect of lifestyle factors on health over a period of time. And what we see in this graph is that, most particularly for women, but for both genders, as your body mass index rises, your age-adjusted relative risk of diabetes increases as well. And by the time you get to a body mass index of 35 or above, women have a 92% increased risk of developing diabetes compared to healthy controls with a normal weight. For men, it's lower at 42% increase, but still a very substantial increase in risk. So there have been a number of seminal studies which have shown that lifestyle change can progression to diabetes. And the first of these large studies was a Chinese study, the Darking study, which looked at 577 adults with impaired glucose tolerance and randomized them to either standard care or one of 3 personalized interventions. And I think this is the important thing, that the interventions weren't personalized. There wasn't just one standard package that was rolled out to everyone. So people were either randomized to a diet arm, where depending on their weight, they were given a total calorie allowance of 25 to 30 kilocalories per kilo of body weight. Or they were randomized to an exercise arm, where they were asked to increase their exercise by 1 unit a day. And again, this was personalized depending on what activity the person could do. 1 unit was either 30 minutes of mild exercise, 20 minutes of moderate, 10 minutes of strenuous, or 5 minutes of very strenuous activity. And then a third group was randomized to a combination of diet and exercise. And what we saw was that after 6 years of follow-up, there was a risk reduction of 31% in the diet group for developing diabetes, and a 46% reduction in the exercise group, and 41% reduction in the combined group. Following on from that, there was the Finnish diabetes prevention study, which looked at a similar number of adults in middle age with impaired glucose tolerance, and again they were randomized to lifestyle intervention or a control intervention. And the control intervention was some fairly general written and verbal information just once a year. But the lifestyle group was asked to lose 5% of their body weight, and they were asked to do this by undertaking at least 30 minutes of exercise every single day of the week. And they had very intensive input from a dietitian. They met a dietitian 7 times in the first year, and then every 3 months thereafter. And by 4 years of follow-up, the intervention group had a 58% reduction in the risk of diabetes compared to controls. The largest of these original studies was the Diabetes Prevention Program in America. And there are some important differences between this study and the previous 2. Clearly, the first 2 were very select ethnic groups, China, Finland. This program actually represented the ethnic minorities in the States very highly, so we had Hispanic groups and Afro-Caribbean groups, for example. It was very large, over 3,000 adults with impaired glucose tolerance, and had a broader age range. It took subjects as young as 25. And so once again, these were randomized to either a lifestyle intervention or control, and the lifestyle intervention required them to lose at least 7% of their body weight, so an even stricter target than the Finnish diabetes prevention program. They were asked to reduce their fat intake to 25% of their total calorie intake and to restrict their total calories, and they were asked to exercise at least 150 minutes a week. There were 2 control arms, both of which were given some general advice to maintain a healthy lifestyle, but they were not given any specific advice beyond that. And 1 control arm, in addition, was given metformin, while the other was given a placebo tablet. And in fact, this study was terminated early at 3 years because it was felt that the extent of benefit in the lifestyle intervention arm of 58% reduction in diabetes meant that it was unjustifiable to continue the trial beyond that. And it's interesting to note that the metformin arm had a lower reduction in diabetes of 31%. So in fact, there have been a number of other studies since then, and I won't go into all of them, but many studies have now confirmed the value of lifestyle interventions in terms of reducing progression from impaired glucose tolerance to type 2 diabetes. And they give varying degrees of benefit, but if we combine a number of these studies, we get a pooled risk reduction of just over 50%. So it sounds as though it would be very worthwhile implementing these kinds of lifestyle programs on a broader basis. But are there any cautions that we need to be aware of? Well, I'd like to tell you about a different lifestyle trial. This is the Look Ahead study, which is effectively viewed as a negative study. It was a study in patients with established type 2 diabetes, and the purpose of this study was to see if they could reduce cardiovascular events, a composite endpoint of cardiovascular death, myocardial infarction, stroke, or hospitalization or angina. And it was hoped that by improving lifestyle, they could reduce the frequency of these complications. Again, it was a large study, more than 5,000 overweight or obese patients with type 2 diabetes, with an average age of 59, body mass index of 36, and 13.5% of them already had cardiovascular disease at baseline. But after 9.5 years, the study was stopped. It was clearly futile, and you can see here that there is absolutely no difference between the control and intervention groups in the frequency of cardiovascular events. But if we look at the data in a little bit more detail, about lifestyle interventions. What we can see is that whether we look at the weight graph here, where we had a dramatic reduction in the first year, or the waist circumference, dramatic reduction in the first year, physical fitness, dramatic increase in the first year, or glycated hemoglobin, dramatic reduction in the first year, these changes all rebounded very promptly. They were very, very difficult to maintain. So that starts to tell us that we need to be a little bit careful about how we translate these lifestyle studies into real life, because in a general population it may be hard to maintain these. I think the other thing that's interesting is if we look up at the top left-hand graph, which shows weight, and this red arm here is the control arm, and what we see is that over the first 10 years of this study, the subjects went down from an average weight of 100 kilos to just over 96 kilos. Now, it's not my experience in Edinburgh that my patients progressively lose weight over the first 10 years of diabetes. Unfortunately, they gradually put on weight. And I think this reminds us that the people who participate in these intervention studies are by and large more motivated than our average patients. So we need to be careful about how we translate these studies into real life. So what might the other barriers be to implementing this kind of lifestyle change? Well, obviously we need to identify people with impaired glucose tolerance. That means screening a lot of people with glucose tolerance tests, and there's a resource implication to that. And the interventions that have been delivered in some of these studies are very resource and time intensive. For example, in one of the studies, they met a dietitian 7 times in the first year. My patients with type 2 diabetes are lucky if I can get them to see a dietitian every 2 or 3 years. So it's not something that we could easily roll out. So there have been some studies that have looked at ways of delivering this intervention in the community. And clearly, every country is going to have to think about their own approach to this that's fitting in with their own culture and customs. In America, they've used an organisation called the Young Men's Christian Association, the YMCA. There's more than 2,500 YMCAs across America, and 46 million people live within a 3-mile radius of a YMCA. So in this particular study, screening was offered at YMCA centres. Rather than delivering the intervention at an individual level, they did group sessions, and they trained the YMCA lay leaders to deliver this, rather than taking a dietitian who's had to go through several years of study and qualification. And as a result, this intervention was a lot cheaper, around $200 per person, compared to nearly $1,500 per person in the diabetes prevention program. And what this data shows is that after a relatively short period of follow-up, just 12 to 14 months, we see that their program, which was modelled on the diabetes prevention program, had achieved a 6% reduction in weight compared to a less than 2% reduction in weight in the control arm. And in fact, there are several other programs that have been rolled out. I haven't got time to go into all of them, but if you're interested to read any, this review article looks at translation of diabetes prevention programs into real-world settings. But I think the key message is that it is possible to develop a less intensive intervention based on these intensive lifestyle trials, and that they can have an impact on progression of type 2 diabetes in at-risk individuals. I'd like to move on to talk a little bit about bariatric surgery now, because some people don't find it possible to comply with diet and lifestyle, and unfortunately for some of these we need to resort to surgery to achieve weight loss. So the SOS study is the Swedish obese subjects study, which has looked at bariatric surgery, and this is data from 2007 that shows that whichever surgical method they use, they achieve significant weight loss compared to the control group on medical management alone. And these are a mixed population in this graph, some of whom have diabetes, but many of whom do not, they're simply obese. But this follow-up study, published a couple of years ago in the New England Journal of Medicine, looked at whether bariatric surgery could prevent progression to type 2 diabetes in obese subjects. So it's important to note that this was a non-randomized trial. It was a prospective study, and they compared usual care against surgery. And in terms of the surgical interventions, 19% of patients had a gastric band, the majority had vertical banded gastroplasty, and 12% had a bypass. And it was a pre-specified secondary endpoint of the SOS study that they were going to examine the incidence of type 2 diabetes at 15 years follow-up. And they had roughly 1,700 patients who'd undergone bariatric surgery and just over 1,700 obese matched controls, none of whom had diabetes at the start of the study. It's worth just pointing out here at the bottom that at this 15-year time point, about a third of the patients had dropped out of the study. Another third of patients hadn't yet reached 15 years duration in the study, so they're only presenting the findings of about 40% of the study subjects. And the participants ranged in age from 37 to 60 years old, with body mass index of at least 34 in men and at least 38 in women. Unfortunately, despite the matching process, there were some differences between the groups. And again, we're reminded that this is not a randomized trial, so there may have been some differences in the patients, which meant that some of them chose surgery over lifestyle management. But in fact, it seemed that the risk factors were greater in the surgical group. They were older, they were heavier, they had greater waist circumference, greater blood glucose, worse insulin resistance, worse blood pressure, worse cholesterol, greater rates of smoking and less rates of exercise. And type 2 diabetes developed in 392 of the control patients compared to just 110 of those undergoing bariatric surgery, giving an incidence rate of 28.4 new cases of type 2 diabetes per 1,000 patient years in the control arm and 6.8 per 1,000 person years in the intervention arm. And what you see here is that the patients who underwent surgery had a hazard ratio of 0.17 of developing diabetes compared to those with medical management. So certainly bariatric surgery can achieve substantial weight loss, and there is evidence that that can reduce the development of type 2 diabetes. How safe is it? This is the complication rates, and at 90 days after surgery, the post-operative mortality was 0.2%, which sounds fairly low, but I think we have to bear in mind that there were 3 deaths in this cohort to achieve something that effectively can be achieved by diet and lifestyle alone. So we have to balance that when we're thinking about what intervention is best for our patients. There were just under 3% of patients who needed reoperation within 90 days for complications, and the commonest complications post-operatively were either pulmonary complications or thromboembolic disease. So, yes, we can prevent progression of type 2 with diet and lifestyle, and similarly with bariatric surgery. But what I'd like to talk about for the last 5 to 10 minutes or so is whether we can actually reverse type 2 diabetes in the early stages. Because, of course, prevention relies on us screening and capturing that very large population with impaired glucose tolerance. And if the lifestyle messages are difficult to get across to our patients with type 2 diabetes, they're potentially even harder to get across to people who don't yet have the disease. So can we reverse type 2 diabetes? Can we turn back the clock? As I've just described, surgery can lead to very dramatic weight loss and remission of type 2 diabetes, but in fact, following bariatric surgery, we see that blood glucose normalizes within days of surgery before weight loss occurs. And there are some hypotheses as to why this occurs. Many of you will be familiar with incretins, and Dr. Haddad mentioned GLP-1 analogs of mimetics. So GLP-1 is a hormone that is secreted from the intestine when we eat, and it promotes secretion of insulin and lowers insulin resistance. So one hypothesis has been that bariatric surgery may alter the secretion of incretins, and that this may be responsible for the prompt normalization of blood glucose. But some researchers hypothesized a different cause. They wondered whether it might be the sudden negative energy balance that results after bariatric surgery. In particular, we know that deposition of fatty acids in liver and pancreas contributes to insulin resistance and inhibits the beta cells from releasing insulin. So could it be that this sudden reduction in energy balance could reduce these fatty acid levels and allow the pancreas to recover? So in 2011, this study, the Counterpoint study, was published in Diabetologia, and this was conducted at Newcastle University in England, and it tested a low-calorie liquid diet, so soups and milkshakes as a way of testing the hypothesis that acute negative energy balance alone could reverse type 2 diabetes. It was a very small study, only 11 people, average age just under 50, and they all had type 2 diabetes with a BMI of 33.6. Predominantly male with just 2 females. And they were studied before commencing the diet and after 1, 4, and 8 weeks of this 600 calorie a day diet. They then picked a group of 8 age, sex and weight matched non-diabetic adults, and in all of them they studied their insulin sensitivity, their liver glucose output, beta cell function, and fat content of liver and pancreas. And After 1 week, the fasting glucose had normalized in the group with type 2 diabetes. We see here from a baseline of 9.2 millimoles per litre, which is roughly 160 milligrams per deciliter, down to normal blood glucose of 5.9. And the white circle here shows the control group, and you can see that actually the fasting glucose came down to control group levels. Similarly, when they measured hepatic glucose output, in type 2 diabetes, after a meal there's an outpouring of glucose from the liver, which contributes to the rise in blood glucose, and insulin helps to suppress this. So that hepatic glucose output was reduced within a week of going on this diet. They also looked at hepatic levels of fatty acids, and what they showed on imaging was a massive reduction in the levels of liver fat, again falling to below those of the control subjects, so the control subjects shown here in the open white circle. Similarly, pancreatic triglycerol levels fell, and the first insulin response increased, not quite achieving control values, but almost. Of course, that was a very short follow-up, that was just 8 weeks. They were then screened again 3 months later, and not surprisingly, they had put on some weight, approximately 3 kilos. This study used the newer International Federation of Clinical Chemistry units for HbA1c, and HbA1c of 42 is 6%. So basically, at the end of the study, they had an HbA1c of 6%, which remained stable. And again, fasting plasma glucose in the non-diabetic range of 5.7 by the end of the study, just rising slightly to 6.1 millimoles per litre. However, on the glucose tolerance test, there was some deterioration shown there, with an average 2-hour value of 10.3 millimoles per litre, so just over 180, and 3 patients that had recurrence of their diabetes with a 2-hour glucose value in the diagnostic range of diabetes. So this is a very short study, it is a very small study, it was carried out in a research setting, it was a very intensive intervention, but it is proof of a concept that beta cell failure and insulin resistance can be reversed by negative energy balance alone. But what we don't know is whether we can translate that into real life practice as part of routine care. Following this study, Roy Taylor's group published the details of their diet on a website, and people were invited to email in with their experiences following this diet if they so wished. And they had 77 individuals who emailed in and were happy to have their details used. They had a median diabetes duration of 5.5 years, but some of them, as you can see, very long duration, up to 28 years. And this group reported, it was self-reported weight, it wasn't verified medically, but an average weight loss from 96.7 to 81.9 kilos. And interestingly, in this population of people who had simply looked at the diet on the website and done it themselves, diabetes had been reversed in 61%. Can we say a little bit more about the factors that predict who might manage to reverse their diabetes? Well, not surprisingly, the more weight you lost, the more likely you were to reverse your diabetes. If you lost more than 20 kilos, 80% of people reverse their diabetes, whereas if you lost less than 10 kilos, only 50% reverse their diabetes. Similarly, the longer you had diabetes, the less likely you were to reverse your disease, but for those who had less than 4 years duration, 73% of them managed to reverse their diabetes. Now, clearly these were very motivated patients who had used their own initiative to look up the website and follow the diet, but it did suggest that this kind of weight loss could be mirrored at home, and similar results could be replicated in terms of reversing type 2 diabetes. So last year, Diabetes UK awarded its largest ever research grant to support a 5-year study looking at whether this could be rolled out in primary care. So this study, the DIRECT study, is the Diabetes Remission Clinical Trial, and it will compare the long-term health effects of the best available type 2 diabetes care with those of a low-calorie liquid diet, followed by long-term weight control. And the specific questions they want to answer is whether intensive weight management is the best way to treat and possibly reverse type 2 diabetes, and whether the benefits can be maintained in the long term as part of routine care in the National Health Service in the UK. This is a picture of Roy Taylor, who's one of the lead investigators in the study. It's going to be rolled out across general practitioner practices in Scotland and the northeast of England, recruiting people aged between 20 and 65 with a maximum of 6 years duration of diabetes. Randomization is going to be occurring by practice, so everybody in one practice will be treated the same way. And the interventional group will be on an 800-calorie liquid diet for between 8 and 20 weeks, so pretty tough diet to follow. But following the diet, participants will gradually have normal food reintroduced over the next 2 to 8 weeks with ongoing support to maintain their weight loss. So some important questions: when will we have the results of this study? Well, the study will complete until October of 2018, so it will be at least 2019 before it's peer-reviewed and published, so not for a little while yet. Is this sort of diet available now? Well, as you've seen, some people have followed equivalent diets, purchasing commercially available diets and milkshakes, but of course these are marketed by private companies, they can be expensive, and we don't have any evidence of long-term benefit. So we're not yet recommending that people with type 2 diabetes follow this diet, even though Diabetes UK is funding this study. It's keeping its previous advice of a healthy balanced diet, low in sugar, fat and salt, and high in fruit and vegetables. But I think this will be a very interesting result to come out in the next few years. So to summarise, I think we've seen that because of the extent of the problem of type 2 diabetes, prevention is vitally important, and there are numerous studies that show that an intensive lifestyle intervention can reduce the development of type 2 diabetes. But there are challenges to implementing and maintaining lifestyle change, and we saw in that Look Ahead study how all the benefits rebounded very promptly. Yes, surgical methods can reverse type 2 diabetes, but this is a scarce resource. It's not available for the majority of people, and it does carry complications. And I think there will be some interesting data to come in the next few years, looking at these very low-calorie diets for reversal of type 2 diabetes in the early years of diagnosis, but this is not yet a standard practice. Thank you very much.
Thank you, Dr. Zamet. Any question? Yes.
Thank you very much for this informative studies. My question is there any data that using the lifestyle modifications plus metformin, because you showed in one of the studies there's a 50% reduction in the incidence of diabetes type 2 in cases of lifestyle modifications with 31%, as I remember, with metformin. But using both together, is there any data or studies?
There have been studies looking at metformin and other studies looking at glitazones as well in terms of prevention of type 2 diabetes. They've been given general lifestyle advice about maintaining a healthy weight and diet, but I'm not aware of any study that looks at these kinds of intensive interventions. And they really are very intensive because, as I say, in our service we would struggle to provide that level of dietetic input to a patient with established diabetes, never mind somebody with pre-diabetes. I think the other issue with using medication is that it is hard to sell that to patients, because I think it's quite reasonable for people to turn around and say, well, you're telling me that this drug is preventing me from getting diabetes, but when I get diabetes I have to go on this drug. Why don't I just not take the drug until I get diabetes? And that can be a difficult argument to sell to patients. And we do come back to the difficulty of maintaining the lifestyle change. After the previous talk, somebody asked a question about, why is there such a high prevalence of diabetes in the Gulf? And I agree with Dr. Haddad. I suspect that one of the worst things the West has done is create the fast food diet and bringing a sort of a Western diet to risky ethnicities. It's probably been a real disaster for a lot of nationalities around the world. So there's no quick fix, and I think even with combinations of medication and diet, it's hard to convince patients to take medication to prevent a condition that they don't yet have. We certainly find with our patients with diabetes, even when we think they're taking their medication, the general practitioners write to us and say, he hasn't collected a prescription for 3 months now, and I only gave him 1 month's supply the last time I saw him. So it's a difficult one, whichever approach you use.
Thank you. Any more questions? Yeah.
Thank you. Which advice would you practice discussing
So, I don't think the microphone was working very well, but the question really was about using metformin for people with insulin resistance and obesity before they've even developed diabetes. Again, some of this may come down to cultural differences. We find it in the UK very hard to convince patients to take medication for an asymptomatic condition, whether it be hypertension, dyslipidemia, or type 2 diabetes that's not symptomatic. And so I think we would struggle in our health setting to use metformin in that situation. Some of my paediatric colleagues have used metformin for children with obesity and insulin resistance, and again, they've often done mixed meal tolerance tests and measured insulin and C-peptide, and tried to pick out the children who might benefit and commence them on metformin. I'm not familiar with whether there is any sort of evidence to back that, but anecdotally they found it wasn't particularly beneficial, so they've stopped doing it. Potentially it might be that some of these children weren't taking their medication. And as you say, we are fairly sort of restricted in terms of guidelines in the UK, so it's not something that we routinely practice. On the other side of the coin, we've had metformin around for almost a century. It's a drug that's very well known to us. It's by and large very safe. We use it in pregnancy for gestational diabetes. We use it in polycystic ovarian syndrome. So arguably, if you're not going to do any harm and you might do some benefit, and you have a discussion with the patient who's in agreement with that, I don't see any problem with that approach.
Thank you. My last question, please. Do you have any experience or data about the use of P1 analogs and reversing the diabetes mellitus once diagnosed, especially in obese people? Thank you.
Again, so there is some data about using GLP-1 analogs to reverse diabetes, and the difficulty there is because you're then into using an injectable preparation, it becomes less acceptable for patients. And when the GLP-1 analogs first came out, I think we all had very high hopes that this might provide some regeneration of beta cells based on animal studies, and that might reverse diabetes. Of course, more recently there have been some concerns about risk of certainly pancreatitis and potentially pancreatic cancer in animal models. So certainly in the UK we've steered away from the use of GLP-1 for prevention. We've also steered away from the use of it purely as a weight-losing drug on safety issues until the pancreatic concerns are more clear. But I think the main difficulty is in selling it to people because of the fact that it's an injection. The main advantage when you try and convince patients to go on it, though, is the fact that they will lose some weight, and patients really like that.
Thank you.
About interpretation of thyroid function tests.
Thank you very much. So what I'm going to cover in this talk really is interpretation of a range of different thyroid function tests. And the reason for going over this is that the symptoms of thyroid disease are often fairly non-specific, and so diagnosis, monitoring, treatment often rely on interpretation test results. So I'm going to start with a very brief review of thyroid physiology and some of the basic principles you need to understand to interpret thyroid function tests. And then I'm going to go through a range of different thyroid function tests and discuss some of them using cases for illustration. So, as a reminder, the thyroid makes thyroxine and triiodothyronine T4 and T3 respectively. T3 is the active hormone, and the majority of T3 is actually made by conversion peripherally by the deiodinase enzyme that's described in the last talk. And production of thyroid hormones is under negative feedback control from the pituitary and hypothalamus in the typical pattern that we see in most endocrine conditions. And so what we actually appreciate is that if everything is in balance, then the thyroid stimulating hormone from the pituitary and the thyroid hormones are both normal, But if we have somebody with an underactive thyroid where the T4 is starting to drift down, the pituitary will compensate by increasing levels of thyroid-stimulating hormone, asking the thyroid to work harder. So the T4 and TSH move in opposite directions in primary hypothyroidism. In primary hyperthyroidism, the thyroid becomes overactive, overproduces T4, and this feeds back to the pituitary gland, which reduces the production of TSH. So again, we see the hormones moving in opposite directions. And these are the most common situations that we will encounter. What I'm going to discuss mainly is other situations. And what we need to think is if the T4 is low or high and the TSH is not responding as we would expect in these situations, then something a little bit more unusual is possibly taking place. So as we said, that's the pattern of primary hyper and hypothyroidism. I won't go into them in big detail, but the causes of primary hyperthyroidism are known to you, Graves' disease being the commonest, multinodular goiters, toxic nodules, and thyroiditis. And we rely quite heavily on the TRAB, the TSH receptor antibody. If it's positive, we feel that's made a diagnosis of autoimmune thyroid disease. And be aware that the TPO is much less specific for Graves' disease than the TRAB is. It's positive in hypothyroidism and other autoimmune conditions, so it's not as useful in this context. And it's important to confirm the cause of hyperthyroidism if possible before we commence treatment, because as Dr. Hayasat has outlined, antithyroid drugs are very rarely needed in thyroiditis, and we simply treat symptomatically with beta blockade. So to illustrate, this is a 34-year-old female with a 2-week history of neck discomfort, some flu-like symptoms, and no family history or past history of thyroid disease. She's tachycardic but has no clinical evidence of thyroid disease, and she's clinically thyrotoxic with negative TRABs. And in this case, the flu-like symptoms and the neck discomfort and the negative TRABs raise the possibility of a viral thyroiditis. So what can we do? Well, we can do scintigraphy, we can do a technetium scan of the thyroid to see what the diagnosis is, and an ESR is often helpful as it's frequently raised in viral thyroiditis. And in this picture of a technecium scan of thyroiditis, what we see is that there is absolutely no uptake anywhere in the gland. In fact, you cannot really see where the thyroid is. And this is, I put this picture up as a reminder that in thyroiditis, the reason for the high thyroid hormone levels is that you have a damaged gland which is spilling out the contents of the follicles. The gland is not overproducing hormone, it's spilling out the hormone that's already made, and that's why drugs to reduce the production of new hormone are not useful. In contrast, this is what technetium scans look like in a normal thyroid, in Graves' disease, where we see increased uptake throughout both lobes of the thyroid. In a multinodular goiter, you see the patchy uptake in the toxic nodules, and in a toxic adenoma, we see one single hot nodule. So in this case, we would treat the patient symptomatically with beta blockade. We would monitor the thyroid function frequently, observe the thyroid hormones falling, and be aware that hypothyroidism can develop. And at that stage, we would need to commence thyroxine for at least the short or medium term. One point that I'll just flag up is that the primary change here is in the hormone coming from the thyroid gland, and the TSH is therefore responding and reacting to it. And there is a lag period between the change in the thyroid hormone and the change in the TSH. So what we see here is that the T3 and T4 rise and then fall, and they reach normal levels a good couple of weeks before the TSH comes back up into the normal reference range. So bear in mind that in a recovery thyroiditis, the thyroid hormones will recover before the TSH does. Hypothyroidism, certainly in the UK, is mostly managed by primary care physicians, so I won't say terribly much about it, and the symptoms will be familiar to you from medical student days. But a couple of points to mention, because, as we've said, it takes a while for the TSH to catch up after changes in thyroid hormone levels. If we make a change to thyroxine in a patient with primary hypothyroidism, we usually wait a period of at least 4 to 6 weeks before rechecking the tests. Pregnancy is a different situation, but in other conditions, we would wait at least 6 weeks before rechecking. Bear in mind that some other medications can impair absorption of thyroxine and therefore affect interpretation of your thyroid function tests, and some of these are available over the counter. So if somebody with primary hypothyroidism looks as though they're not getting enough thyroxine, it it is worth asking whether there are any supplements containing iron, calcium or aluminium, and if so, you should leave 4 hours between these supplements and thyroxine. Bear in mind also that estrogen and anticonvulsants will increase the requirement for thyroxine. So that's the common situations that you will often encounter, but what I'd like to spend the most of this talk doing is focusing on some of the less common combinations of thyroid hormone abnormalities. So in primary hyperthyroidism, we have suppressed TSH with a high T4, but there are certain conditions where we can see a suppressed TSH and a normal T4, so I'd like to consider what some of these are. I've told you about one of these already, which is in fact a recovering thyrotoxicosis, such as a thyroiditis, and that's because the T4 recovers a few weeks before the TSH comes back to normal. In a patient who is on thyroid hormone replacement for hypothyroidism, having suppressed TSH is indicative that we're giving them too much thyroid hormone. So having a suppressed TSH in this value in this situation suggests we need to reduce the dose and recheck thyroid function tests. However, I would just remind you that there are some patient groups where we purposefully aim to suppress the TSH when they're on thyroid hormone replacement. And these two situations are patients with secondary hypothyroidism and patients with thyroid cancer. So in secondary hypothyroidism, we have a normally functioning thyroid, but we have a failing pituitary, which isn't producing enough thyroid-stimulating hormone, and therefore the thyroid becomes underactive. So of course, when we replace with thyroxine, we find that the TSH will often remain low. That doesn't mean that we give them too much thyroid hormone, it means that the primary deficiency has arisen from a failing pituitary gland. So in patients with pituitary disease on thyroid hormone replacement, we assess the adequacy of therapy by the T4 alone, and we aim to keep it in the top third of the reference range. In patients with thyroid cancer who've had thyroidectomy, and often this has been followed up with ablative radioactive iodine, we purposefully suppress the TSH with high doses of thyroxine, and this is to make sure that there is no stimulation of any small amount of thyroid remnant. So in these situations, you shouldn't reduce the thyroxine in the face of a suppressed TSH. Can a patient be thyrotoxic if they have a suppressed TSH but a normal T4? Well, of course they can, because the other thyroid hormone that we have to remember is T3. But certainly in our centre, if you request thyroid function tests, you don't routinely get a T3 level, you have to ask for it specifically. So in the face of suppressed TSH and a normal T4, if your centre doesn't routinely give you a T3, do remember to ask for it, because some patients can have a pure T3 toxicosis. There's a range of other conditions that can suppress the TSH. Some drugs can do it, and a talk on amiodarone-induced thyroid disease would take up half an hour on its own, but amiodarone can have non-specific effects on thyroid hormone dynamics, including suppression of the TSH. Non-thyroidal illness is an illness outside of the thyroid, which again causes a disruption to thyroid hormone dynamics. And when people are acutely well, rises in glucocorticoids, rises in cytokines such as TNF, can suppress the TSH. So seeing a suppressed TSH in a patient with a different acute illness does not necessarily mean that they have thyroid disease. If none of these situations are present, then a suppressed TSH and a normal T4 should make you think about subclinical hyperthyroidism. In other words, this is a thyroid that is starting to become overactive, and the situation is maintained in equilibrium by the pituitary reducing levels of TSH to compensate for this thyroid that's starting to become overactive. So should we treat subclinical hyperthyroidism, and what evidence is there that it can cause harm? But this is data from the Framingham study from the 1990s, where they took just over 2,000 patients over the age of 60 and followed them up over a period of 10 years to look at the incidence of new atrial fibrillation. And they subdivided these patients into those with low, slightly low, normal or high thyroid stimulating hormone. And what we see is that the line on the top of the graph, this one here, for patients with low TSH, these patients had a relative risk of atrial fibrillation that was 3 times that of patients with a normal TSH. So we do believe that having a permanently suppressed TSH increases your risk of atrial fibrillation. The The other concern is osteoporosis, and there is data to suggest that having suppressed TSH lowers your bone mineral density at both the femoral neck and the radius. And in postmenopausal women with subclinical hyperthyroidism, we see bone mineral density losses of 2% per year over and above what you would expect from age alone. There is data to suggest that giving people thyroxine and treating the subclinical hyperthyroidism with antithyroid drugs and restoring TSH to normality can reverse these changes in bone mineral density. What is lacking is any evidence that this reduces the risk of fractures. So there aren't any randomized control trials suggesting that you can reduce fracture rate in these patients, but we extrapolate from this data to suggest that having a permanently suppressed TSH could be detrimental in terms of increasing the rate of atrial fibrillation and increasing the rate of osteoporosis. And this is applicable, we feel, not just to patients with subclinical hyperthyroidism, but patients with hypothyroidism on excessive doses of thyroxine who are suppressing their TSH. So we said a little bit about the risk of complications, but in subclinical hyperthyroidism at the top, what is the risk of progression to overt thyroid disease? Where approximately 1% of patients per year with suppressed TSH will progress to overt thyroid disease in an elderly population. In a younger population, the figure is probably much higher, because what you're simply doing is catching people with early onset of thyrotoxicosis. So for anybody with suppressed TSH, you want to follow them up. They may develop overt hyperthyroidism very promptly. But for people with a long-term suppressed TSH, you want to consider treatment if they're at risk of osteoporosis, so that would include people over the age of 60 or postmenopausal women. Certainly if they have a history of osteoporosis or heart disease, and if you have a concern about atrial fibrillation. If anybody has symptoms suggestive of thyrotoxicosis, and that would also be an indication to treat them with antithyroid drugs. So as we go along, we'll fill in this table with the causes of the different thyroid abnormalities, and that's covered the causes of suppressed TSH with a normal T4. I'd now like to talk about having a high T4 in the face of high TSH. And this is a patient who was referred to me by a general practitioner with funny thyroid function tests. She had commenced thyroxine in 2005 in a different GP practice, and when she moved to this new GP, the GP had looked back at the tests and thought that something wasn't quite right. First of all, at diagnosis, she only had evidence of what we would call subclinical hypothyroidism. Her TSH was raised, but her free T4 was normal. And thyroxine was commenced perhaps a little bit prematurely in that situation. On thyroxine, then, the original GP never managed to normalise her TSH, despite ever increasing doses of thyroxine taken up to 150 micrograms about 5 years after she commenced treatment. And at that point, shown here, you can see that now her free T4 has gone above our local reference range of 21. So her new GP then reduced the thyroxine, and then eventually stopped it because the T4 remained elevated, and at that point the TSH rose up to 20, and that was when he referred her in for a further opinion. So I want to speak a little bit about what the differential diagnosis of a raised T4 and a raised TSH is. In a patient on thyroxine, it can represent imperfect compliance with medication. So we said that the T3 and T4 levels change more rapidly than the TSH does. In a patient on thyroxine, if they don't take their medication, their T4 levels will come down. About a week before they come to clinic, they realise they're going to have a blood test done, they start taking their medication again, they put their T4 levels back up to normal, but the TSH hasn't had time to recover. So you see this abnormality. You can also have assay interference. So some people can develop antibodies which can then interfere with the thyroid hormone assay and can cause effectually an artifactual result. And we get around this by sending the sample to a different lab that uses a different methodology to make sure that there's no evidence of interference, and we can also screen for interfering antibodies. And this relies on you having a conversation with your clinical chemist. There is a condition called thyroid hormone resistance, where there are defects in the thyroid hormone receptors at a cellular level, and so even though we have very high levels of thyroid hormone, that particular tissue isn't seeing enough of the thyroid hormone because of resistance at the receptor level, and this feeds back to the pituitary, which continues to churn out TSH. And this is is something which an endocrinologist could assess for. Finally, and probably least commonly, would be the situation of a pituitary adenoma producing TSH. So in this case, the primary driver is coming from the pituitary with a high TSH level, which then causes the high T4 level. This lady had a past history of headaches. She'd had some purulent discharge from her breast, which certainly wasn't galactorrhea, and she'd had some proteinuria, which had been investigated with no cause found. And she was on no other medication apart from thyroxine, with no over-the-counter medications that could affect absorption of thyroxine. She had no family history of thyroid disease. And on examination, she had no signs of primary thyroid disease. Thyroid peroxidase antibodies were negative, which would go against her having an original diagnosis of hypothyroidism, given that Hashimoto's is the most common cause, and there was no evidence of interfering antibodies. We had planned at that stage to check for thyroid hormone resistance, but we had also done pituitary blood tests, bearing in mind that TSH-OMA was in the differential. And at the age of 67, where she has gone through the menopause and her ovaries are not working, she should have had very high gonadotropins. Hers were undetectable, indicating a level of pituitary failure. She also had a very raised prolactin, and although she did pass a short synaptin test, a stimulated cortisol of 451 was only just above our local pass mark of 430. So at that stage we became worried that there might be a pituitary lesion. On gross testing to confrontation, the visual fields were normal, but we requested an urgent MRI. I don't know that that projects terribly well actually, but what you can see here is a massive 2.5 by 2.9 by 4.5 centimetre mixed signal lesion in the pituitary fossa, this area here indicating some central hemorrhage. There was some local mass effect, and here you can see the adenoma again shown here, absolutely massive. It's abutting the internal carotid arteries bilaterally, and there's compression of the optic chiasm. So in fact, this lady had probably had a very slow-growing pituitary adenoma for many, many years, producing TSH. The original GP didn't appreciate that, but the new GP essentially made the diagnosis by understanding that her thyroid function tests were not typical of somebody on thyroid hormone replacement, and sending her up for further assessment, and she was urgently referred to our pituitary surgeon. So that's covered the conditions that cause a raised T4 and a raised TSH. We've already covered primary hypothyroidism, and now I'd like to come to the combination of high TSH but normal T4. And this is subclinical hypothyroidism, which we've mentioned already. The prevalence varies anywhere between 4 and 10%, and the main cause is an autoimmune thyroiditis. So essentially, this is somebody who is starting to develop hypothyroidism, the thyroid is starting to become underactive, and the pituitary gland compensates by pushing up the levels of TSH. So how important is it, and do we need to treat it? We've already discussed it in the context of pregnancy, as Dr. Hayasat has discussed. It is important to treat it. But outside of pregnancy, there is some weak evidence of adverse effects. It can affect your lipid profile adversely, it can cause hypertension, it can be linked to adverse cardiovascular risk factors such as a rise in CRP or arterial stiffness. What we don't have is any hard endpoints, so there's no suggestion that subclinical hypothyroidism causes an increase in myocardial infarction, but you may wish to treat it if this patient has, for example, pronounced dyslipidemia. There's no convincing evidence that it causes symptoms, but we're often in a difficult situation where the patient has had this test done because of symptoms that could be attributable to thyroid disease, such as tiredness, such as weight gain, and they may be very keen for a trial of thyroxine to see whether it makes their symptoms better. Looking at subclinical hypothyroidism in a little bit more detail, the Wickham study, which was conducted in the northeast of England, looked at the natural history of thyroid disease and tells us a little bit about how likely people are to progress from subclinical to overt hypothyroidism. And they looked at just under 3,000 adults and followed them up over 20 years, and looked at various risk factors to see what was associated with an increased risk of hypothyroidism. So if you had a persistently elevated thyroid-stimulating hormone, then roughly 2.5% of those patients would convert to overt hypothyroidism each year. If you had strongly positive TPO antibodies, another 2% would convert each year, and if you had both risk factors, then it was roughly 4.3% conversion per annum. So I put in there in brackets pregnancy and infertility. We would consider those differently, as already discussed. But in patients outside of pregnancy, we would want to consider the risk of progression when deciding about treatment. And once patients are on thyroxine, we would aim to normalise their TSH as we would in overt hypothyroidism. Finally, I'd like to come on to a situation where we have a low T4 and a low or normal TSH. And again, I'm just going to take you through a case history to illustrate this. And this is a 49-year-old female who presented to the GP with tiredness and irregular periods, and she thought she might be approaching menopause, but the GP thought, given that she was tired, perhaps she might be hypothyroid, and checked some thyroid function tests. So her TSH is within the normal reference range, and her free T4 is low. And if you ask yourself, what do these thyroid function tests mean? You would remember from the very first slides that in primary hypothyroidism, the TSH should be elevated. So you would realise that this isn't primary hypothyroidism, but unfortunately the GP didn't realise that, and he commenced her on thyroxine without thinking any further on the tests. The patient felt better, the GP was happy, time went by, he repeated the thyroid function tests. And now she had a T4 that was comfortably in the top third of the reference range, but a TSH that was undetectable. Of course, if we look at the original thyroid function tests and we appreciate that this isn't primary hypothyroidism, we may already be starting to have a suspicion that the cause is coming from the pituitary and that what we're dealing with is secondary hypothyroidism. But given that the GP thought they were dealing with primary failure of the thyroid gland, he interpreted that low TSH as meaning that she was over-replaced with thyroxine. So in fact, he reduced the dose of medication at that point. And then 1 month later, she was admitted to hospital as an emergency with a visual field defect. I think that projects a little bit more clearly, but again, you don't need to be a radiologist or an endocrinologist to see this massive pituitary macroadenoma. So in fact, this lady did have secondary hypothyroidism. What she had was a non-functioning adenoma, which was compressing her pituitary and preventing production of TSH. And of course, the concern is that she may be failing to produce other hormones, such as ACTH, and so these patients can be cortisol deficient and become very seriously unwell if we don't pick it up. So this is actually a really important pattern to be able to recognise. So in pituitary disease, what we find is that we have a low T4, and the TSH is often inappropriately in the normal reference range. And so in this situation, normal is not normal, because with a low T4, we should have a high TSH. And if the pituitary is failing to push the TSH up, that's inappropriate and it's clearly a pituitary problem. And again, in this situation, we judge adequacy of replacement by the free T4 level alone. So that's really taken you in a very rapid whistle-stop tour of a range of different combinations of thyroid function tests, and hopefully taking you through some of the thought processes that we as endocrinologists go through when interpreting these abnormalities. It's a reminder that actually many endocrine results can be worked out from first principles if you understand how the feedback loops work and you understand what one hormone should be doing in response to another. It allows you to interpret the tests appropriately. So don't just think about what the test is, think about what the test should be. Remember that changes in TSH lag a little bit behind changes in thyroid hormone. In patients with hypothyroidism on thyroxine replacement, a low TSH implies over-replacement, but do remember those important caveats of thyroid cancer patients and patients with pituitary disease in whom we should disregard the TSH and look solely at the T4. And perhaps one of the most common patterns that internists and general physicians might encounter is patients with hypothyroidism on thyroxine with a high or normal T4 and high TSH, which can indicate poor concordance with medication. Thank you very much.
Thank you, Dr. Thanos, for this comprehensive practical presentation. We have only time for one question. Please. Yes, please. Good question.
It's a very rare question what happens. Some patients misuse thyroxine for certain purposes, like weight reduction, and they don't report it to the doctor. So sometimes we see these patients TFT abnormalities, so what we call flirtatious thyroiditis. How it will show the figures? Now my second question is this term called sick thyroid syndrome. What is that?
So, sick thyroid is actually the same as what I described as non-thyroidal illness. I'm not going to go through these slides in great detail, but it's just really a reminder that there are many things that become abnormal in acute illness. Tumor necrosis factor, interleukin, glucocorticoids, but all of these can have an effect on your thyroid function test. So sick thyroid and non-thyroidal illness are interchangeable terms. You can see a variety of abnormalities. You can see a suppressed TSH from these factors. You can get reduced conversion of T4 to T3. So you can sometimes see a slightly high T4 level because less of it is being converted. But in that situation, if you measure the T3, it tends to be low, whereas in overt thyrotoxicosis, you would usually have a high T3 as well. The key thing is to try and avoid measuring thyroid function in acute illness that is unlikely to represent thyroid disease. And that can sometimes be difficult because if somebody comes in with atrial fibrillation and a pyrexia and a tremor, they could be rampantly thyrotoxic, or they may have severe chest sepsis triggering atrial fibrillation, which could cause an abnormality of thyroid function. So I think it's something to sort of discuss with your local endocrinologist, but bear in mind that illnesses outside the thyroid can suppress the TSH, can push up the T4, can lower the T3. They can cause almost any pattern of thyroid abnormality, and it can be challenging to manage. And sometimes it's only with hindsight that we're truly certain that that abnormality was temporary and related to the other illness.
My first question.
And your first question was about people taking thyroxine for other purposes such as weight loss. And that is a challenge. In the UK, we have a number of women who feel tired and difficulty losing weight, particularly in middle age. We do have some less scrupulous practitioners who will prescribe thyroxine, or some of them purchase it off the internet. Some of them will take alternative preparations, natural desiccated thyroid, for example, which again they can purchase over the internet. In terms of the pattern of tests that you would see, what you may see is normal thyroid hormone levels but a suppressed TSH, so a pattern of subclinical hyperthyroidism. In other words,
which may indicate pituitary as well.
Yes, I mean, as they give themselves their thyroid hormone, what the pituitary should do is switch off the TSH to compensate. And it is difficult because, of course, if they don't admit to taking the medication, then it's very difficult to get to the bottom of it. And sometimes with patients who are having real issues with medication, we sometimes end up admitting them to hospital for a period of observation. Really, it's to ensure that they can't have access to other medication. And their TSH won't change rapidly, but you can serially follow their thyroid hormone levels and see the T4 falling, for example. But it's a challenge to manage that situation.
Thank you.
Thank you very much. Thank you very much.
Excuse me, Doctor. Thank you.
Thank you.
There's a space. How other?
دكتور جهاد حداد. دكتورة دانا حياصة.
Smile.